Hi, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. And today I will be speaking with Dr. Titilola, or Lola Falasinnu, who's the first author of the article entitled The Problem of Pain in Rheumatology, Variations in Case Definition Derived from Chronic Pain Phenotyping Algorithms Using Electronic Health Records. Lola, I want to thank you for taking the time to speak to me and our listeners on behalf of all the authors of your paper and this important topic with the increasing use of electronic health records and the importance in rheumatology of pain. So shall begin. So what made you decide to study the use of electronic health records and definition of pain?
So thank you for inviting me to talk about our work. So for a bit of a background, up to 7% of adults in the US live with autoimmune rheumatic diseases, or ARDs, including lupus, Sjogren's, and scleroderma. And living with these conditions confers multiple challenges. Pain is a frequent self-reported symptom, and it's often one of the first symptoms of these conditions. Pain takes many forms in ARDs, including musculoskeletal headaches or migraines, abdominal pain, and even secondary fibromyalgia. And despite treatment advances in rheumatology, including the advent of highly specific biologics, pain remains an undertreated problem in this realm. And depending on the ARD diagnosis, up to 65% of patients are on long-term opioid therapies. And these conditions also have higher rates of opioid overdoses compared to the general population. But before we start to think or even talk about optimal pain management modalities in ARD, we need to understand the burden of pain in these conditions the way we understand, say, cardiovascular disease and kidney disease as important comorbidities in rheumatology. And I know I said before that chronic pain is a symptom, but it's not just a symptom. It's a health condition that leads to disability and distress, as we all know. In this paper, we highlight the need for reliable and detailed estimates to guide population-wide interventions and also guide resource allocation. So to solve this problem, we leverage electronic health records, or EHRs. EHRs offer a rich data source for studying disease burden, as most people know. But accurate case definitions and algorithms are crucial to ensure precision in estimating disease burden in EHR. So we propose using computational phenotyping algorithms. And this is a clinical data science method that's often used to subtype patients in heterogeneous EHR data. And our goal here was to describe and compare different phenotyping algorithms for chronic pain using EHR data from rheumatology clinics. And the phenotyping algorithms that we developed here combine pain scores, pain diagnostic codes, pain medications, and pain interventions.
Thank you. So it leads into what was the source of your medicine, of your data, and which particular EMR did you use?
So the data used in the study came from the electronic health records of patients attending rheumatology clinics here at Stanford Healthcare. And Stanford Healthcare sees approximately 1 million outpatient visits per year. The EHR system used in this study was Epic, and Epic is a widely used EHR vendor in the US. Epic was used to extract relevant data fields for analysis, such as demographics, diagnostic codes, medications, procedure codes, and we also even looked at clinical and encounter notes. Specifically, we assessed the Epic records via a back-end relational database known as Stanford Research Repository, or STAR, which facilitated easy data querying and retrieval for research purposes. STAR serves for many of us here at Stanford as an interface or repository that allows researchers to access and analyze HR data in a structured and efficient manner.
Thank you. I think you really did go over the methodology you used, and I think why it was chosen makes sense to me. But my only question really is, can you explain just a little more detail of, you said there were four, I remember reading there were four algorithms. So how did you come up with that?
Okay, so those so in terms of the methods, we identified five ARDs. There were ankylosing spondylitis, psoriatic arthritis, Sjogren's syndrome, lupus, and systemic sclerosis. And we limited the data, the time window, to patient visits in 2019. And so those four algorithms, when you combine them, there are 15 unique combinations. So for pain scores, we used the 11-point numerical pain scale rating. For diagnosis code, we extracted ICD codes for painful conditions such as abdominal pain and joint pain. And for pain medications, we looked at a myriad of them, like opioids, NSAIDs, and even anticonvulsants. And for pain interventions, we identified procedure codes that we routinely used in interventional pain management, such as physical therapy and nerve blocks.
Okay, thank you.
Yeah.
It just struck me, I'm sorry. Using ICD codes for pain, what's your feeling, how accurate? Like, how often would somebody bill, for argument's sake, an ICD code of lupus and then a second one of abdominal pain, if that was their major complaint, or joint pain or whatever?
Yeah, that's a really good question. So in terms of what really happens in the clinic visits, and we don't really know. That's why we looked at those four phenotyping algorithms and the combinations of them, right? So hopefully, like in an encounter, if the structured data elements are used, say, the pain scores, or like the ICD codes, or the medications, or the interventions, hopefully one or several of them will be captured during that visit. Like, so for example, in this study, for the pain scores, we asked that, okay, you had to have a pain score of 4 and over at least twice, separated by 3 or more months, right? And hopefully, if the ICD codes is not captured, then the pain score is captured, or the pain intervention is captured, or the pain medication is captured. Now, if you decide that, okay, well, they might not be captured in structured data elements, the next step in this line of research that we're doing is actually look at the clinical encounter notes and use natural language processing to see if that's also captured there.
Good, thank you. And so leads into, what were the major findings in your study?
Okay, so in the results, we found that we found 3,000 patients that were seen in 2019. And like I mentioned before, there are 15 ways to combine these 4 data elements in the HRR. Out of those 15 algorithms, we identified a reference standard from a previously published manuscript. So this was a trimodal algorithm that combines pain scores, diagnosis codes, and medications. And chronic pain prevalence was lowest in unimodal pain phenotyping algorithms, meaning only one data element was included. For example, the prevalence was 15% using medications, it was 18% using pain scores, 21% using pain diagnosis codes, and 22% using pain interventions. In comparison, the prevalence using the previously published trimodal phenotyping algorithm was 37%. We also found that the estimated prevalence of chronic pain increased with increasing number of data elements included. So not surprising, the highest estimated chronic pain prevalence was the multimodal phenotyping algorithm that included all 4 data elements. And the estimated prevalence based on that algorithm was 47%. However, this quadrumodal phenotyping algorithm yielded a 10% overestimation of chronic pain compared to the previously published algorithm. And similarly, unimodal phenotyping algorithms yielded underestimation of chronic pain. For example, if, like you mentioned before, using pain diagnosis codes only would yield a 16% underestimation.
Okay, thank you. And it's also struck me how well was a good uptake on your patients of filling out the pain score?
So Let's see. We found pain scores was available. Pain scores were available for about 95% of patient encounters, and it's often recorded as part of routine clinic visits.
Okay, good. Well, that's amazing that people actually
Yeah.
fill that out. That's great.
Yeah.
And
So,
yeah, go ahead. Sorry.
so I'm not sure, like, in the clinical encounter, I think it's usually the medical assistant that asks the question about, how much pain are you in today? Could you rate the scale? Like, you using the visual analog scale.
Mhm.
Yeah.
Well, that's still a good uptake. It's great. Um, it really struck me, though, that I know I read that you eliminated RA patients. And could you just elaborate a little bit for people listening why?
So this was one of the limitations of the study. We did not include patients with RA. Specifically, patients in our clinics with RA are selectively given the RAPID-3 questionnaire at each visit. And as you may know, the RAPID-3 includes pain measures and functional status questions. And we felt that this systematic collection of pain-reported data in RA could artificially inflate the prevalence of pain in this subgroup, making comparisons with other conditions less reliable.
Okay, thank you. The other
And
is,
so, obviously,
yeah, go ahead.
these findings may not be generalizable to rheumatology clinics where RA is like the most prevalent. And we also acknowledge that our findings may be more applicable to settings with similar disease distributions as ours.
Yeah, along those lines, it struck me that the most frequently diagnosed patient had Sjogren's syndrome. Like, really? I mean, over lupus, I mean, this, going back to the generalizability, how were these selected in any way? It just,
So I think because this was like a specific time point, 2019, we didn't look at, and in our, so when I look at 10 years worth of our data, so the prevalence is much higher. We have a lot more RA patients in our clinics.
sure.
And, also we have, I think lupus and Sjogren's are about the same. And when we looked at, I think it's RA followed by PSA in terms of prevalence, and then lupus and Sjogren's. But when we looked at administrative health databases like MarketScan,
Mhm.
um, Sjogren's and lupus tended to have about equal prevalence when we used the same case definition that we used.
Okay, thank you.
Yeah.
And do you think that this choice could have influenced the results? Pure speculation. Like,
The
you
choice of
mentioned the RA issue while you eliminated it, but it's just, so I guess, are you saying that you have to look at similar groups for the generalizability? I guess that's my real question.
Yeah, I think this might not generalize to um settings where, RA makes up most of the patients.
Mhm.
And it's not going to generalize to RA patients because, and as I mentioned before, the HR does not capture the universal truth. In the paper we note that we're a tertiary health care center. Stanford is a tertiary health care center. So the findings in our setting may not generalize to community-based practices just because of the case mix that we get here.
Sure, I understand. So, well, I think you addressed the question. These were all these were patients only recorded once, but they had two visits
Yeah.
with the pain. Okay. And so what do you think the implications and the conclusions are? The take-home messages that our readers are, is it good? Do you have proposed algorithms if you are going to use EMRs, or we shouldn't just base it on this? What do you think?
So I read the editorial that was written about the paper,
Yeah,
and the authors mentioned that our paper is a cautionary tale for using EHR, and I couldn't have written it better.
good.
And that said, our study has several important implications and conclusions. First is that this was the first empirical study, to our knowledge, to show that established common modes of phenotyping chronic pain can lead to substantially varying estimations of the prevalence of chronic pain. So this underscores the importance of accurate case definitions for chronic pain in EHRs. Second is that by comparing different phenotyping algorithms, we created a reference for biases in case definitions for chronic pain in EHR. For example, these findings could be used to estimate the extent of possible misclassifications or corrections when using datasets that cannot include specific data elements. Like I mentioned before, in the US, we have administrative claims data that include Medicaid, also Truven Market Scan, which are employer-based databases. And third, in terms of clinical relevance, these findings emphasize the need for improved understanding and management of chronic pain in rheumatology practice. And given its impact on quality of life and healthcare utilization, addressing chronic pain is crucial for optimizing patient care and outcomes. And lastly, our study's findings have implications for research methodologies and health policy decisions related to chronic pain in rheumatology and writ large. It underscores the need for accurate data collection and robust methodologies to inform evidence-based practices and policy interventions.
I think it's perfect, and I think it is true. I think the editorial had some very interesting points to be made, and I think my bias is in, as you know, we're getting more and more into big data, you know, with algorithms and AI. So I think these paper like yours is very important. I really believe it, you know, even if and your conclusion is maybe this isn't the best way and we better look it up. Those are important conclusions. I do not play down the least of that there was no great algorithm, because people are increasingly using big data and EMRs in everything. And pain, as you pointed out, in rheumatology is so important and maybe overlooked, and we want to get good estimates. I think this was a very important paper. I want to thank you. Anything you'd like to add that maybe we missed?
Okay, so I think our study sets the stage for future research. So our findings need to be validated. So I mean, meaning the chronic pain phenotyping algorithms need to be validated. And we also need more studies exploring contextual determinants of the pain experience in individual patients with autoimmune rheumatic diseases. And future studies could also investigate the impact of interventions on chronic pain interventions, on chronic pain outcomes in patients with ARDs.
Thank you. And I want to thank you, Dr. Titilola Falasinnu, for taking the time to read the findings and the implications of your, I think, very important paper looking into what is ever-expanding use of EMRs and the importance of pain. And to our viewers and listeners, I please read the complete paper titled "The Problem of Pain in Rheumatology, Variations in Case Definitions Derived from Chronic Pain Phenotyping Algorithms Using Electronic Health Records." And as pointed out by our guest, there is an accompanying editorial by Drs. Hans Clark and Anne Fitzgerald, who respectively of the Anesthesia and Pain at the University of Toronto and Department of Rheumatology, McGill University, Montreal, Canada, and it's titled "Are Electronic Health Records Sufficiently Accurate to Phenotype Rheumatology Patients with Chronic Pain?" And I'll let the audience come to their own conclusions, and I hope you read both of them. They are both available on the journal's website at jroom.org, and both will appear in the March print edition of the journal. Thank you. Thank you for joining us, and hope you will join us next week when I'll speak to the author of another article of importance and interest in the April 2024 edition of the Journal of Rheumatology. And I'd like to hear your comments on X at jroom or by email at manuscripts@jroom.com. Thank you for listening.